All right, we're now recording, just so you know. So we left off last time with the interaction between the hypothalamus and the pituitary, which I think is just a beautiful example of the brain and the hormones working, or the endocrine system working together in two unique ways. I mean, basically neuronal or hormonal. Uh, and one thing to remember is that some neurohormones act as releasing hormones and other act as inhibiting hormones when they are released from the hypothalamus and act on the pituitary. Some actually would inhibit others. So this is really how the hypothalamus controls the anterior pituitary. Remember that when the posterior pituitary, there are direct axons linking the two together. So the release of the neurohormone that would travel through the capillaries of the blood and then actually enter into the pituitary, that is only the anterior pituitary gland. There are several hypothalamic hormones, and again, I'm not going to hold you responsible for all of these names. But I would like to go ahead and start understanding their general nomenclature, which will help us in the future when we get to them, and you are more responsible for the individuals. But in general, there are 6 releasing hormones, 2 inhibiting hormones, and 2 other hormones that have at least 4 names, making it all the more confusing. Somebody have a question? And I also wanted to point out, if anybody does have questions, please feel free to jump right in. I'm not doing a good job of monitoring the text chat during the lecture. So just go ahead and feel free to jump right in, just like you would in a regular class. I can't see hands or the chat or anything, so just please feel free to interrupt at any time to ask a specific question about the material. But there are 6 releasing hormones. These are the thyrotropin releasing hormone, the growth hormone releasing hormone, the gonadotropin releasing hormone, melanotropin releasing hormone, corticotropin releasing hormone, and kisspeptin. Kisspeptin is sort of an odd name, and that is due in part to the fact that the receptor was not discovered until 2001. And recently, scientists have gotten a little cuter in how they derive their names. Kisspeptin is thought to trigger puberty by causing more release of gonadotropin releasing hormone. And your book covers this a little bit, but any guess where kisspeptin was discovered? Pennsylvania, in Hershey, Pennsylvania, where Penn State University is located. There are 2 inhibiting hormones, the growth hormone inhibiting hormone, which is also called somatostatin, and the gonadotropin inhibitory hormone. The gonadotropin inhibiting hormone is, like I said, also called somatostatin, and the name, I think, helps to consider if you really think about the nomenclature and the derivation that led to it. Somato means of or related to the body, and statins are something that would reduce something else. Can anybody think of a famous statin in medicine?
The ones used for blood pressure.
Exactly. Yeah, there are, of course, really, I think the most prescribed medicine in the United States are statins, which, as she pointed out, reduce lower blood pressure in individuals that it is high in. And there are, two other hypothalamic hormones, dopamine and hypocretin or orexin. Dopamine, which is the name that I'm primarily going to use to refer to this one, is also a well characterized neurotransmitter, of course, but it's also a neurohormone within the hypothalamus. It's called prolactin inhibitory hormone, and obviously it inhibits prolactin by its release from the hypothalamus and action in the anterior pituitary. And hypocretin is also called orexin. Yes. And it also can inhibit melanotropin. And when it does that, it's called melanotropin inhibitory hormone. So three different names there. Note that I will usually be referring to this one as dopamine. And hypocretin and orexin have two different names as well. I've worked with pharmacology to target this system, and am in the good, primarily a dopamine researcher, hence my tendency to use that name. I also tend to use hypocretin. Orexin implies that this molecule can, excuse me, can modulate feeding behavior. And one interesting thing there is based on our studies in rodents, at least the group that I was in demonstrated that at least some of that might have to do with arousal and motivation. Obviously, if you are sort of aroused and up more, you will be more motivated to eat more, and you might actually need to eat more. There's still, a little, so that would have more basis with the name of hypocretin or cretinism than orexin or feeding. But, it is generally thought to play roles in arousal and feeding. But anyway, here's a figure. This doesn't have all of the tropic hormones on it, but here are just some examples of how they would interact with each other. And you can see prolactin releasing hormone there on your far left. And prolactin inhibiting hormone or dopamine would interfere with its action, would prevent its action on or block its action at the level of the anterior pituitary, where it would typically stimulate prolactin, which would have effects primarily on the breasts. The thyroid hormone, thyroid would obviously release the thyroid stimulating hormone, which would then act on the thyroid to release T3 and T4 to produce a wide array of effects on growth and metabolism. The corticotropin releasing hormone is one we'll talk quite a bit about later in the semester. Acts on the anterior pituitary to lead to the release of ACTH, which would then act on the adrenal cortex to release cortisol. You might recall that I brought up the example of Cushing's disorder previously. In Cushing's, you would then have an inability of cortisol to act on the hypothalamus in a typical negative feedback loop. So the body is always sort of in a constant stress response, which can lead to depression, weight gain, amongst other, outcomes. The growth hormone releasing hormone and the growth hormone inhibiting hormone, or somatostatin, would both act on the anterior pituitary to regulate the release of growth hormone, which is involved in making us look like Shaquille O'Neal. Gonadotropin releasing hormone is very involved in the release during adolescence in particular. It's involved in sexual maturation and would act on the endocrine cells within the anterior pituitary, where you would see the release of either luteinizing hormone or follicle stimulating hormone to act on either the male or female gonads to lead to release of androgen, estrogen, and or progesterone. Recall that in the anterior pituitary, the release is into the blood, and that would be an example of hormonal regulation of hormone release. In the posterior pituitary, there are no blood vessels that connect the hypothalamus to the pituitary. There are direct axonal links. So this would be an example of neuronal rather than hormonal regulation of hormone release. And remember, just as an important review point, there is a third type of regulation, which would be humoral. By that, essentially, the receptors in the original release site would be responsive to something like insulin or even an ion like calcium ions or sodium ions, and be responsive to that chemical in the blood rather than a hormone or a neurotransmitter itself to regulate its own release through negative or positive feedback. But instead, neurohormones produced by the hypothalamus travel to the posterior pituitary via axons. And yes, again, recall that there are three mechanisms: neural, which would be an example of the posterior pituitary; hormonal, a good example would be anything involving the anterior pituitary; and humoral, which I just explained. Here is a nice visual, dissociating the posterior and anterior pituitary. The posterior pituitary, you can see on your left there, and the direct axonal links to the receptors in the posterior pituitary, where you would lead to the release of things like oxytocin. In the anterior pituitary, rather than being released or traveling through an axon, the chemical is released, or the neurohormone is released into the capillaries of the blood, which then travel through blood vessels to the anterior pituitary, where they would lead to the release of several hormones into the blood to travel throughout circulation. Here's just another example of the posterior pituitary here, when there would be a stimulus leading to the release of the neurohormone in the hypothalamus. It would then travel down the hypothalamo-hypophyseal tract, or basically axons. I'm not going to hold you to that name, where it would act in the posterior pituitary as neurohormones, and then release the hormone into the blood to act at target tissue throughout the body. The posterior pituitary stores and secretes two polypeptide hormones: ADH, also called vasopressin, antidiuretic hormone, has a direct action on the kidneys to regulate water release and retention, and oxytocin, which is involved in pair bonding, and also is used an example in this lecture in positive feedback, particularly regarding the milk letdown response. The antidiuretic hormone, or vasopressin, is synthesized in the hypothalamus and transported to the posterior pituitary by axons, not in the blood. ADH is then released into the circulatory system and carried to the primary target tissue in the kidney, where it would regulate water retention and reduce urine volume. Here's just a complicated example of that in visual form. If there were a change in osmolality of the blood, you would have a direct effect on neurons in the hypothalamus, which I would be a example of humoral hormonal regulation. Then you would see a release of the neurohormone through axons directly to the posterior pituitary. That would be an example of neuronal hormonal regulation, where you would see the release of ADH, which would then act on the kidney to alter water retention and urine volume. Oxytocin is synthesized in the hypothalamus. In addition to pair bonding, it's very important in birth. It causes uterine contractions. Pitocin is a chemical that I'm sure you've heard of if you've ever experienced a birth directly or been around someone that has. Pitocin is a synthetic version of oxytocin, and it's often used to induce labor. The uterus is only responsive to oxytocin when progesterone levels are low after an extended period of elevated estrogen that occurs during pregnancy. There are multiple sort of checks and balances here to prevent premature labor. And as I've already mentioned, and will again here in a moment, oxytocin is very important in regulating positive feedback and the suckling reflex. Specifically, when the baby suckles at the level of the alveola, there is oxytocin release, which causes cells in the mammary body to contract to release milk. Anterior pituitary hormones are called tropic hormones. Tropic hormones have endocrine glands as their target. And actually, if you'll let me pause here, I just want to take a 2-minute break for everyone to refresh, take a stretch, and I will be right back. Oops. All right there. Yeah. Remind me going forward to give you guys, at least one break partway through these long lectures, which are luckily going to be coming to an end soon as we get more and more into, the discussions. All right. So as I was saying, the anterior pituitary hormones are referred to as tropic hormones. Tropic hormones are those that have other endocrine glands as their targets. Specifically, the growth hormone, thyroid stimulating hormone, adrenocorticotropin releasing hormone, lydotropins, beta endorphins, which also act in the periaqueductal gray, in the sort of the pain response, melanocyte stimulating hormone, luteinizing hormone, follicle stimulating hormone, and prolactin. All of these would have, unique target tissues throughout the body in their endocrine roles. Oh, yep. So that. So a little bit on some of these. One example that I want you to at least be aware of, in part because I think it's a relatively simple one to remember, and a good example of a negative feedback loop is the thyroid stimulating hormone. Thyroid stimulating hormone is also known as thyrotropin. It stimulates the synthesis and secretion of thyroid hormones from the thyroid gland. Thyroid stimulating hormone secretion is controlled by thyroid releasing hormone from the hypothalamus. So, what does your thyroid do? It has many functions, really. It has widespread function throughout the body. It controls how quickly the body uses energy, makes proteins, and controls how sensitive the body is to other hormones. Deficiencies in the thyroid signaling can lead to alterations in energy metabolism and growth ultimately, and it can also lead to a presence of a goiter. There are many famous people throughout history that have had issues with the thyroid. In the then this is very much a issue that is related to diet in many cases, in the case of iodine deficiency. And in most developed countries like the United States, that really isn't an issue because we fortify baby food and have incredible, financial resources. But you see a lot more iodine deficiency induced thyroid issues in more developing countries. However, there is a form of thyroid disorder called Graves' disease that is prevalent in the United States. And here, essentially, the immune system would attack the thyroid gland and alter its ability to function properly. There is medication that can be given for the treatment of Graves' disease. And many people have had thyroid issues, many notable people without developing large goiters and these sorts of things in our country. Oprah has had issues. George H.W. Bush, had a thyroid issue, and I believe even started to develop a goiter, but was treated before it became noticeable. But the thyroid system is regulated through a very nice negative feedback loop. Basically, the thyroid releasing hormone from the hypothalamus would lead to the release of thyroid stimulating hormone, which would then lead to the release of T3 and T4 at the level of the thyroid, which would act throughout the body to influence growth and development. Other hormones increase catecholamine effects. Catecholamines are like dopamine, noradrenaline. And it would also, influence metabolism. T3 and T4 would then be released through the blood where they can act at, there are receptors for T3 and T4, both at the level of the anterior pituitary and at the hypothalamus, where they can act on these areas to result in the release of either the thyrotropin releasing hormone or thyroid stimulating hormone, and therefore serves in this sort of regulated negative feedback. If there were a disruption in the negative feedback, you would just continue to dump out T3 and T4, which would alter many different things. Yep, T3 and T4 are synthesized from iodine and tyrosine, which is why dietary issues are a primary cause of thyroid disorders in developing nations. Thyroid hormones diffuse through the target cell membrane and bind to receptors in the nucleus. Recall that there are some hormones that would act on receptors in the plasma membrane, and others that can diffuse through the plasma membrane and act intracellularly. Thyroid hormones affect nearly every tissue in the body because the receptors for T3 and T4 are very widespread, which I think explains the wide array of effects that you get on metabolism, growth, and maturation. Thyroid releasing and thyroid stimulating hormone help control thyroid hormone levels. Exposure to stress and cold would both increase thyroid releasing hormone. prolonged fasting decreases thyroid releasing hormone. So here you can see, this in an illustration. In response to stress or hypothermia, you would trigger the release of thyroid releasing hormone from the hypothalamus, and then because it's acting in the anterior pituitary, you would get hormonal, not humoral or neuronal, control of endocrine release at that level, which would then lead to the release of thyroid stimulating hormone from the anterior pituitary, which is released into the blood, has widespread action, unlike neurotransmitters, also tends to be released in more of like an analog type, sort of constantly ascending release event rather than digital sort of point to point dot pattern of release. Although it is true that some chronologically related release of hormones does occur, or time related release does occur. But anyway, T3 and then T4 would be released from the thyroid gland if thyroid stimulating hormone binds to receptors in the nucleus of cells within the thyroid gland. T3 and T4 would act in most, many different cells and tissues throughout the body to produce a wide array of effects, but it would also act at receptors at the level of the anterior hypothalamus and the anterior pituitary and the hypothalamus, where it would shut down release of the neurohormone or the hormone when it's prevalent in high levels to tightly regulate these functions. And remember, that is the key of endocrine function, the fact that it is this sort of tight, controlled balance between release and inhibition. Not too much, not too little. I've already talked about, abnormal thyroid conditions a little bit. But you can have hypothyroidism resulting from iodine deficiency, which can cause inadequate thyroid hormone synthesis, which results in elevated thyroid stimulating hormone secretion. Thyroid gland enlargement, which is what a goiter actually is the thyroid getting very large. And as a result of thyroid stimulation, thyroid hormones frequently remain in the low to normal range. Graves' disease is basically hyperthyroidism, and this would be the immune system sort of attacking the thyroid system. It's characterized by goiter, and most patients have long-acting receive a long-acting thyroid stimulator or a thyroid stimulating hormone like immune globulin that would be injected into their plasma. Oh, and I also wanted to point out that tumors have been known to cause thyroid issues in hyperthyroidism, particularly if they are tumors associated with the thyroid. So hyperthyroidism typically caused by a tumor or Graves' disease, and this would be much more common in America. Hyperthyroidism, much more common in developing countries, and you see this in childhood, which leads to the concept of cretinism. Cretinism isn't really a term that is used much in medicine because it has been really used in many different contexts, so it leads to a lot of confusion. But originally, cretinism was used to describe the effect of hyperthyroidism, and basically it leads to the appearance of dwarfism. The subject is very short, hypodeveloped. In addition, there can be a goiter that results from insufficient iodine in the diet. And adult hypothyroidism tends to also be autoimmune. Here are just some examples of some of the effects of thyroid disorders. You can see in A, the effect that's known as uh, exophthalmos of Graves' disease, sort of like bulging of the eyes. In B, you can see a goiter or an enlarged thyroid resulting from iodine deficiency. And lastly, there you can see an example of cretinism. So this would be, it's not the same as dwarfism, but some similar characteristics. Stunted growth, is I guess one of the key features. It would be most visibly obvious. The adrenal glands are another one that I wanted to go over. The adrenal glands are located on top of the kidneys and composed of an inner medulla and an outer cortex, both of which are release distinct forms of hormones. The adrenal medulla is associated with epinephrine primarily, but also norepinephrine. It would be involved in a variety of responses, including increased cardiac output, increased blood flow to skeletal muscles, and increased blood flow to the heart. Also, an increased release of glucose and fatty acids into the blood. And then also you have the adrenal cortex. Well, you also have the adrenal cortex, where you can have the release of cortisol, aldosterone, and sex steroids, which would have a variety of functions, including increased protein and fat breakdown in the case of cortisol, increased sodium reabsorption and potassium excretion, and minor impotence in males can result. In females, you can have the development of some secondary sexual characteristics such as axillary and pubic hair. So here is an example of the adrenal medulla being stimulated to lead to the release of epinephrine and norepinephrine, where it would act on the body to alter metabolism, increase heart rate. Some of this could be associated with sort of like the fight or flight response. So when the hypothalamus would be stimulated by stress or physical activity or low blood glucose levels, that would lead to the release of cortisol, which would then lead to the release of ACTH, which would lead to the release of, which would lead to activation of the adrenal medulla, where it would then release and have these effects throughout the body. One unique feature here is that in contrast to most of the hypothalamic and pituitary hormones that tend to be more peptide-based or protein-based, the adrenal cortex, in the adrenal cortex, all hormones are steroids. These would be lipid soluble and are carried in the plasma by protein carriers. Remember, those that are water soluble do not need protein carriers. There are three hormone types: aldosterone or mineralocorticoids, cortisol, glucocorticoids, and androgens. Glucocorticoids control carb, fat, and protein metabolism, are anti-inflammatory, repair injury, manage stress, and can dull pain. Mineralocorticoids control electrolyte or salt and water balance, are not helpful in repairing injury or managing stress, but they do manage pain. Adrenocorticotropin releasing hormone is necessary to maintain the sensory activity of the adrenal cortex. Corticotropin releasing hormone is released from the hypothalamus and stimulates the anterior pituitary to secrete ACTH, which would then be involved in the release of norepinephrine. Here's another example of this. I've sort of already gone over the exact hormonal responses in the previous diagram, but so again here, So when there would be like stress or physical exertion, or hypoglycemia, like low glucose in the blood. This can activate neurons in the hypothalamus to lead to the release of corticotropin releasing hormone, which can then lead to the release of ACTH, which can then act on the adrenal cortex to do multiple things, but one of which would be to release cortisol, which would then act through negative feedback back at ACTH to result in the reduce the release of ACTH at the level of the anterior pituitary, and to result in the reduce the release of corticotropin releasing hormone at the level of the hypothalamus. Can anybody recall what disorder this is the negative feedback of this circuit is disrupted in? Cushing's. The answer is Cushing's disorder. That was not on the test this time, but it will be eventually. So here, a little bit quick thought question. Cortisone is a drug similar to cortisol that is sometimes given to people who have severe allergies or extensive inflammation or who suffer from autoimmune diseases. Corticosteroid is a steroid. Taking this substance can chronically damage the adrenal cortex. Can anybody think of why that might be? Well, essentially, it is a disruption in the regular balance of cortisol acting on the receptor and the regular negative feedback mechanisms that would regulate cortisol levels in the body. So when cortisone is, given, your body will have sort of alterations in the negative feedback response, which is thought to lead to damage in the adrenal cortex that can be long lasting. So that's one reason that long-term use of cortisone and possibly other steroids is not considered to be an appropriate medical treatment. I just went over that, chart, so I'm not going to do it again. There are several effects on aging. What happens to the endocrine system when we get old? The endocrine glands differ in how they respond to the aging process. Some of them, have like really major effects as you age, and some are not affected at all. It really depends on the endocrine system we're talking about. As I said, some experience a gradual decrease in secretion as you grow old, while others are not affected whatsoever. One example is there is a decrease in growth hormone as we exit puberty and age, so we do not continue growing. The decrease is greater in people who do not exercise. So, if you continue to exercise, that might contribute to increases in growth hormone. And this has also been associated with not losing lean muscle mass as opposed to adipose. And this is one reason that, growth hormone is popular in these so-called anti-aging clinics, which even exist here in Denver. Again, these things are a delicate balance. I, excuse me, would be personally concerned, I guess I remain skeptical and would like to know more of the long-term effects of growth hormone on other cells. For example, are the receptor targets on cells that develop into tumors, most likely in some cases? What are some of the negative effects of long-term growth hormone use? But it is true that you would probably see some response on a lack of loss of lean body mass. However, you could also just hit the gym. Melatonin is another example of a hormone that decreases as people age. which may influence sleeping patterns. And as you age, your sleeping can become disrupted, altered. People might start sleeping in lesser lengths. And this may also affect the patterns of other hormones like growth hormone and testosterone. The thyroid only decreases slightly with increased aging, but there can also be age-related damage to the thyroid that can lead to thyroid dysregulation.
Excuse me, I just
There
have a
does not
question.
appear to be an age-related decrease in the ability to maintain blood glucose levels. However, there is an age-related tendency to develop type 2 diabetes, which is, of course, more related to dietary and exercise and weight gain choices. So that brings us to the end of the actual lecture that you will be tested on. Remember, there will be one question on the test that comes from your article that we're going to review on Wednesday. And at this point, I would like to go over a little bit of review of some of the key points that I want you to be aware of. So what is the difference between the endocrine system and the nervous system? Does anybody want to answer that? Anybody? Well, there's several major differences. One would, of course, be that hormones are released into the blood, whereas the nervous system most commonly functions through chemical transmission through synaptic clefts. There is also some, direct electrical regulation through gap junctions in the nervous system. But for the most part, the endocrine system involves the blood, with, I guess, the rare exception of neuronal regulation of hormonal release, for example, in the posterior pituitary. But still, when the posterior pituitary is stimulated, it would release its hormone into the blood. And really, I guess that's a neural hormone that would be regulating the release of the primary hormone. So that's one big difference between the endocrine and nervous system. Another would be basically the pattern or frequency of how these release events occur. While there can be some temporal control of endocrine release, endocrine release tends to be sort of more of an analog signal rather than a sort of dot, dot, dot type digital response that you see with the nervous system. By releasing its chemical into the blood, the effects of the endocrine system are much more widespread. They would be acting at all tissues and cells throughout the body where there is a receptor target for that particular hormone. So those are some of the main differences that come to mind when I think of the differences between the endocrine and nervous system. I would be very ready to describe that. Similarly, I would like you to be able to describe what are the three classes of hormones based on chemical structure. Anybody know this one? All right, I'll just give it to you. They are the amines, the peptides, the proteins, and the steroids. Amines are going to be like dopamine. Peptides, recall, are those little branch chains of amino acids, which are basically baby proteins, which are longer branches. And steroids have that very characteristic ring-like shape, and we know that they are released from the adrenal cortex. But also, these are associated with the sex hormones like testosterone. And these steroid hormones tend to be longer lasting than the protein hormones. And the protein hormones seem to be longer lasting than the peptide hormones, in part just due to biophysics and what it takes to break down the specific bonds, with proteins being longer than peptides, and the bonds being easier to break of that form versus the steroid. So which endocrine glands are in the periphery? I would like you to know, while I don't think that you need to memorize all the different hormones at this point, I think that would be a bit much. I would like you to be able to identify and list the major endocrine glands and where they are located. Are they located centrally or in the periphery? Well, so first, what endocrine glands are located centrally in the brain? The pineal gland and the hypothalamus pituitary complex. What endocrine glands are in the periphery? The adrenal and thyroid glands, which are standalone glands. And then there are endocrine cells listed that contained within other organs, such as the pancreas, thymus, ovary, and testis. Describe the hypothalamus's role in regulating the pituitary. I'll just go ahead and field this one too. The hypothalamus, would release neurohormones that would act on receptors within the pituitary to lead to the release of hormones into the blood. It is the brain's primary output regulator of hormonal release. The hypothalamus can interact with the pituitary in one or two ways, depending on if it's interacting with the anterior or posterior pituitary. If the hypothalamus is interacting with the anterior pituitary, it releases a neurohormone into the blood, into the capillaries that would then be released into the anterior pituitary, where it would act at receptors to release hormones into the blood. If we're talking about the posterior pituitary, the hypothalamus would release neurohormones through axons that extend into the posterior pituitary to release hormones into the blood. There are typically receptors at both the level of the hypothalamus and the pituitary to control negative and positive feedback, negative feedback being more common. So for example, in the case of thyroid, the thyroid, you would have thyroid releasing hormone being released from the hypothalamus, where it would act on the pituitary to release thyroid stimulating hormone, where it would act on the thyroid to release T3 and T4, which would act at the level of the hypothalamus and the pituitary to reduce the release of thyroid releasing and thyroid stimulating hormone. Here's just a diagram here that I throw in of the activation of the anterior pituitary, which would of course be through the blood, with the main difference being that the posterior pituitary would be an example of neuronal release. And I mean, that's another important one that I want you to know. The three main mechanisms of hormonal regulation: neural, neuronal, and hormonal regulation. Here already, just from this diagram, you have two nice ones. Neuronal being a description of the type of hormonal regulation that occurs between the hypothalamus and posterior pituitary. Hormonal being a form of regulation between the hypothalamus and anterior pituitary. But you could also say that the hypothalamic nerves are going to be responsive to insulin or changes in the osmolality of the blood, either of which would trigger neurons in the hypothalamus as well. And that would be an example of humoral regulation. So I'd like you to be able to list and describe those three as well. And you know this is coming, right? I mean, like, give me an example of a negative or a positive feedback loop. And for the exam, I'm not going to be requiring you to know one in particular. I personally do better with learning actual mechanisms rather than fake ones, but you could just do a general description, like a releasing factor from hypothalamus to a stimulating factor from the pituitary, acts on organ and body, negative feedback of that release of the endocrine hormone from that endocrine organ in the body to result in the release, to reduce the release of the releasing and stimulating hormone. The example that we gave in the class, what negative feedback was of the thyroid stimulating hormone system. So, again, thyroid releasing hormone released from the hypothalamus, which leads to the release of thyroid stimulating hormone, which would then act on the thyroid to release T3 and T4. There are receptors at both the level of the hypothalamus and the pituitary that detect T3 and T4 levels, and if they're too high, will reduce the amount of thyroid stimulating, thyroid releasing hormone. What are 3 ways to show a relationship between a hormone and a behavior? This is from our first lecture. And note that I reminded you at that time that, I consider this to be important, as it is a big conceptual thing that we'll keep in mind while we're doing sort of critical analyses. For example, the article that we're going to be discussing on Wednesday, in addition to other studies as we go through the course. But there are 3 conditions that must be satisfied by experimental rather than just sort of subjective or philosophical opinion to establish a causal link between hormones and behavior. 1, a hormonally dependent behavior should disappear if the hormone is removed or the actions of the hormone are blocked. 2, if the behavior stops, replacement of the hormone will restart the behavior. And 3, hormone concentration should be directly correlated with the behavior. This would mean that the higher the hormone concentration, the greater the display of behavior. And one thing to keep in mind here is that there is a sort of a temporal element to hormonal signaling. And when you're measuring the concentration of the hormone, could greatly influence your results in number 3. So you have to have some sort of idea of when and how release occurs, which is sort of hard to do without invasive animal experimentation in a valid model of a human system. So next week, we're going to get into this article here, which I think you'll find very interesting. Enjoy reading that, and definitely do read it. I believe there is a reading check that I would like you to participate on, and then we can discuss this article and critique it. I think it's an important thing to learn how to constructively analyze, others' content, scientific content out there, which will be a good exercise that we will be participating in on Wednesday. So bring your red pens. Here, I'll stop sharing before I call for questions here, but I'm stopping the recording. We'll stop sharing, and now I'm going to stop recording.